Good evening, Anu. And it's in Myanmar, it's an evening, early evening. So everybody, hope all every well. And today my talk is an approach to weakness. And I was asked to do this topic. So the weakness could be due to anything and everything. But our focus on the neurological cause of the weakness. Okay, so as usual, and my standard is always history, physical examination, investigations, and treatment. Now, when you look at it, there's 4 pictures. Which one you think it is neurological weakness? Anybody? The one with the walking frame, or the guy with the dumbbell ball, or the sleeping girls, or the head drop? Which one would be caused by a neurological cause? Anybody, any idea? Okay, if you know the answer, type it in here. Which one you suspect the cause of the weakness could be a neurological cause? Or number 4, that is what I think. There is no right or wrong answer. I think head drop is most likely a neurological cause. Okay. And when people are old, you can have a reticulopathy, you can have a, you don't need to remember the name, and just for the brainstorming, for example, extensor neck muscle myopathy or cervical reticulopathy, myasthenia gravis, you name it. The one with the walking frame could be a neurological cause as well, could be due to anything. And the guy with the making the pulling his face with the dumbbell is most likely psychological. Look at it, all the muscles and everything is fine, and it's normally quite common, especially young and fit men or women. That has something to do with their expectation. They normally come to see me after the flu or whatever. I'm weak. Actually, when you do the examination, they are stronger than you. And so they are most likely a functional weakness. And the one may be just a general tiredness. Okay, so the weakness could be due to anything. Now, patient complaint, listening to what patient said, you have a big idea what would be the site of lesion. For example, distal weakness, patient will tell you foot drop. I trip over, doctor, when there is a carpet or mat or going to the monastery, or they trip over. And loss of slippers. Of course, I do not come across that sort of the complaint in the Western countries because we wear in here a shoes. But if you wear slippers, oh, I lost slippers all the time. I did not know whether I was on the slippers or not. And wrist drop. They didn't say you wrist drop, but they would say you the weakness. If everyone trying to make your hand drop and then grip it, put your 2 fingers and grip it, and then pull it out, you notice that your grip is weak because this is a mechanical position. So then put your wrist on the normal position and put 2 of your fingers and grip it. You couldn't pull your fingers off. So why I am saying it, some people do have a radiant palsy. They come to see you the wrist drop. Actually, when you mistaken, that could be ulnar nerve, because most of the ulnar nerve is something to do with the grip. But if you ask the patient, if you correct the patient with your hand and ask them to grip it, you will find normal grip. Another one is, of course, loss of the grip, dropping things, and I can hold the pencil, I can hold the, my keys are dropping, and loss of fine motor function. For example, I can count money. In Burma, you have to count so much money because of the inflation, and loss of slippers. Proximal weakness, they come with a slightly different story. They will tell you, oh, I got a problem in the climbing stairs or coming down to the stairs, and I can't stand up from the squatting positions or from low chair, and combing your hair, making your bra, for example, and unable to reach the shelves. So that are the weakness. Why it is important, I will explain to you a little bit detail in later. This weakness is most likely a neuropathy. And proximal weakness is most likely either reticulopathy or myopathy. Okay? Fatigue, you have to ask the difference between fatigue and weakness. Fatigue is normally seen in neuromuscular junction disorder, for example, myasthenia gravis. And they will probably say nyang there in Burmese. And when they are doing something initially okay, and then you lost the strength, that is a fatigue. You can examine fatigability, for example, in myasthenia gravis. You can make like a, like a flipping your shoulder like a chicken about 20 times, and you assess the patient before flipping and after flipping. The most example for the fatigue is if you are not used to the gym, when you do the press up, and depends on how fit and how strong you are, after a few press up, you can't extend your arms anymore. That's a fatigue, and this is not a weakness. And then patient will falling over. I got a fall, I got a head injury, so far and so forth. Now, dragging off the feet. Dragging off the feet is you walk like a robot. Like a robot. And I don't know how I can explain in Burmese. If you see some of the musical, and you can see some of the theater, that's sort of the actor, Tim Man, he was walking like a very stiff manner. Dragging off the feet is normally upper motor neurons. And you could see in the like a paraplegia, or you could see in the one-sided dragging of the feet in hemiplegia. It's stiffness. So look at the way the patient walk, and dragging of the feet is most likely due to upper motor neuron lesion. Speech and swallowing are, to be honest, for the localization, speech and swallowing has a very little localization values. For example, if you have a myasthenia gravis, you can have a speech and swallowing problems. If you have an anterior onset disease, motor neuron disease, you will have it. And when you have a stroke, you will have it. So speech and swallowing, and even for the polymyositis, 20% of the patient affect a speech and swallowing. However, why I'm put in here, because for the someone who developed speech and swallowing problems, you can ask, is the problem is with the liquid or solid? It is not a rule, but started with the liquid. Dysphagia is most likely neurological problem, and solid dysphagia is most likely structural problems. For example, carcinoma of the stomach. And sometimes speech and swallowing problem could be due to the functional neurological disorder, i.e. in the old days, we call it a hysteria. I'm sure you have heard of the globus hystericus. They will tell you, I'm very weak, doctor, I can't swallow alone. When I was practicing in Burma, that is what they say, alone. And ask them, do they have the weight loss? If they do not have the weight loss, and they do not have a recurrent chest infection or choking, it is unlikely significant. Spinal involvement is always telling you the central problem rather than a peripheral problem. For example, spinal cord problems and sensory involvement. There are two types of sensory involvement. If you have a sensory level, I will show you picture later on. If you have a sensory level, and this is a spinal cord, okay, and then you have a different pattern of the sensory involvement, which can be either due to reticulopathy, which can be due to the hemisensory loss. It could be due to anything. I will tell you a bit more detail later on. Now, you have to think about symmetrical or asymmetrical. Symmetrical is most likely inflammatory metabolic. Asymmetrical could be due to mechanical, for example, reticulopathy. Okay, for example, every reticulopathy can give you the quadriceps muscle weakness. However, its symmetrical thigh weakness could be due to the polymyositis. Okay, now you have to look at the systemic features, and then it's no need to explain in detail. Patient with a renal failure, liver failure, and can be presented with a weakness. Patient with a malabsorption syndrome can have a vitamin deficiency. Alcoholism associated with the muscle wasting, and an autonomic dysfunction. If it is an autonomic dysfunction, it could be like Parkinson's disease, it could be Guillain-Barré syndrome, and it could be due to a spinal cord syndrome. So there's no localizing values for autonomic dysfunction. However, you need to ask, what sort of question you need to ask? Or you have to assess swinging blood pressure, palpitation, flushing, abnormal bowel movement, so on, etc. Because autonomic dysfunction kills the patient. And weight loss, weight gain. Weight loss could be due to motor neuron disease, thyroid disease, and malignancies. Weight gain due to be like a kidney disease and salt and water retention, etc. Okay. Now, after listening to the patient, and you have to find a patient sometimes tell you, yes, its weakness occur. So you have to quantify how acute is acute. Hyperacute is always vascular. When I am saying hyperacute, I am talking about within split seconds, within 1 to 2 minutes. And that is always vascular. It could be DIA, it could be the stroke, or it could be the wrist drop due to the vasculitis. That's always tell you a vascular. Acute could be inflammatory or like a complexion. Inflammatory is, for example, like a Guillain-Barré syndrome. And if you are drunk and if you put your hand across the bench and sleep on it, you can have a Saturday night palsy. That is acute, that is a pressure. I do remember my late grandma's friend, and she put the wooden clap. I'm not quite sure you still use in Burma. They call it a night there. So they put around your thigh or your feet and stiffen up and then release it. Because of the recirculation, you feel warm. So people think it is a anyang piede, a putote, something like that. This woman, old lady, put this at night there in her thigh, and she fell asleep overnight. The next morning, she got a foot drop. Of course she would, because she got a sciatic nerve palsy. So that is a neuropraxia due to the pressure on the nerve. Another example is if you are thin and if you sit on the bench and you probably feel your feet are started pins and needles. So this is again pressure. Chronic and stable, it could be due to anything. For example, if you have a gut injury in your hand, you have an ulnar neuropathy, it's quite evident. Another one example is a chemotherapy induced neuropathy. You were given chemotherapy and then it's once you stop offending or toxic agent, it's not going to progress. Chronic and slowly progressive, I would say, if you could and correct my slide later on, chronic and slowly progressive is most likely degenerative. For example, like a diabetic neuropathy, Parkinson's disease. Relapsing and remitting is most likely inflammatory, like MS, polymyositis in remission, or myelopathy, if you have a slight spondylitis, and patient can come and go. And of course, I'm not going to tell you because like a HNPP rare condition, hereditary liver to pressure nerve palsy, but you don't need to remember anything about this. Clinical context, I have already explained to you trauma, post-infection vaccination, like a inflammatory they are, like a Guillain-Barré syndrome. You have to look about underlying comorbidities. For example, someone who has underlying SLE. If you have a rheumatoid arthritis, it can be myelopathy, and patient may well have a carpal tunnel syndrome. So, medications, some of the medications are neurotoxic, and travel history, family history, some diseases are genetic disease, myoglobinuria. I'm going to tell you a little bit more, and you have to ask, patient wouldn't know whether it's myoglobinuria or not. You normally ask the patient normally will give you exercise intolerance story, muscle ache and pain. Some patient may tell you, I got the swelling, features of the renal failure, and also a patient will have high color urine. When I'm saying high color urine, I'm not talking about like a Chinese tea color or beer color. I am talking about like a swine sauce. It's most likely myoglobinuria. And so it's really dark one, and not just a Yin color. And Saturday night palsy is normally in the West. Normally in the West, I got the two questions I'm going to answer. Normally in the West, they drunk and they fall asleep. And when sleep on the bench before they go home, and they fall asleep on the bench, and one of the arm is crossing the the back bench and fall asleep the whole night because under the influence of the alcohol. And the next morning when they woke up and they can't move your hand, so it's they call it a Saturday night palsy. And another one is tripping is a patient complaint, isn't it? Some patient may be intelligent or they are educated, they will tell you foot drop, but they will tell you, oh, I tripped on my foot. And foot drop is probably more precise, and tripping is just like a symptoms, like a temperature and I feel hot. COVID vaccine, of course, it does not cause a weakness, but COVID vaccine, like any vaccine, they can have a systemic symptoms like a fatigue or anything. Of course, COVID vaccine, like any vaccine, and once in a million, they can give you the Guillain-Barré syndrome. But on balance, have a vaccine if you have. And by the way, in the recent study show Indian vaccine, and although they cannot protect you 100% in healthcare professional, that was last week, they found out the recent study in the healthcare professional, when they have a full vaccination and they found reinfection, or when they have a COVID, and the severity of the COVID is less. So please do take a vaccination, because you all are in the healthcare frontline healthcare workers. Okay. Now, shall we do the next one? Other causes like a musculoskeletal is like a osteoarthritis, mechanical, and I was a junior in the Southampton General Hospital. One of the patients cannot move, and actually what she got was a fractured hip. So she got a little bit of the neuropathy, and she got a fall, and the neuropathy was because of the diabetes. It was quite stable, but when she has a fall, and she was keep explaining, I got a weakness, and I couldn't move on this one side. So she was admitted, and the next morning when my consultant examined, and what she got is a hip fracture. So be careful, and you have to look at the whole body. Psychological, I have already touched in the earlier, and some people feel weak. And when you have a psychological, you can have a giveaway weakness. I don't know how to explain giveaway weakness. A giveaway weakness is, and for example, if you put your arm like a extended, like a how can I say it, like a chicken wing, and then you push the pressure on the shoulder at elbow, and the more you push, the pressure will put you more and more. So it's like a giveaway weakness. That is most likely psychological, and also history is very inconsistent, and patient may tell you, oh, I can't do that, but at one second they are doing something else. So that deserves one session, and it's normally for the neurologist, so I'm not going to touch. And rheumatology, like a rheumatoid arthritis, SLE, vascular claudication. The best example is a patient will feel weak because it's pain. And also when the patient is pain, they don't want to move. And normally you can see patient in the back pain. Back pain can be so bad, so they don't move, or I don't want to move. But when you examine the power with the muscle power, with encouragement, and patient can move. Okay, so be careful. And neurological complication due to underlying systemic disease, like a diabetes, endocrine, thyroid, liver disease, renal disease, malignancy, hematological, like a lymphoma, autoimmune, drug and alcohol. I'm not going to back into post-infection. So that is quite simple and straightforward. So just one concept. Is calcium metabolism is some vitamin D causes weakness? Yes, because it is to do with a so vitamin deficiency can cause a weakness. Yes, because calcium is important for the muscle contraction mechanisms. So that is why vitamin deficiency can cause the weakness. Okay, and even you have a sunny country, you can have a vitamin deficiency, because some of the people don't want to have a dark skin, and so they are take too much covering, and you can have a vitamin D deficiency even in the Africas. Okay, next slide, please. And next one, please. Thank you. So physical examination, you have to do general examination, okay, or whether patient has a lymphadenopathy, and liver or hepatosplenomegaly, etc. And gait, and there are different gait. whether this patient has a Parkinsonism gait, hemiplegic gait, spastic gait, and so on and so forth, or cerebellar gait. So you can look at it, and you have to look for whether this patient has upper motor neuron or lower motor neuron lesion, or combination of both. For example, if you had a stroke and if you have a diabetic neuropathy, of course they can have a both. Or patient can have like a rheumatoid arthritis patient, where patient can have a cervical spondylosis and cervical reticulopathy, and patient can have myopathy, or patient can have a carpal tunnel syndrome. So there will be combination in some cases, and distribution of the weakness. I will show you the picture in the later on, and any cranial nerve involvement. And cranial nerve involvement is normally like a stroke, like a Guillain-Barré syndrome. You can have a cranial nerve involvement, and distal or proximal. Distal is normally neuropathy, proximal is normally reticulopathy or myopathy. And symmetric or asymmetrical, I have already explained to you. And sensory involvement is normally either neuropathy, and if it is a sensory level, it is a normally spinal cord. And also, by looking at the cranial nerves involvement, you can probably tell you site of the lesion. It's most likely brainstem. I will show you picture later. Motor examination, and I just make easier for you, because whenever a patient, a student, or the doctors were asked to do neurological examination, they call panic. Not need to. It's simple. Inspection, palpation, percussion, auscultation, and pronator drift. Okay, inspection, muscle wasting, any fasciculation, that is telling you lower motor neuron. Or if there is a contracture, that is telling you this is not acute, this is a long standing. And palpitation is tone and power. Okay, tone increase, tone decrease, power. And percussion is the tendon hammer, exaggerated deep tendon reflexes or not. Auscultation, you will listen to the carotid bruit, you will listen to the heart, whether this patient has atrial fibrillation, or you can even listen to anywhere, for example, like an AV malformation. Pronator drift. What is pronator drift? Is if you close your eyes and put your hand in the prone position, as if you know, like a statue in the Indian statue with the tray on your hand, but the elbow, everything extended. Close your eyes, and if there is a real weakness, not a psychological weakness, hands not lower. Hand is not going to lower on that weak side, but hand is slightly pronate, because pronator muscles are stronger than supinator muscle. So that is called pronator drift. Okay, and sensory examination, just touch, joint position, and vibration. Rumba sign is important, because if the rumba sign is positive, patient is not stable. Be careful and tell the patient to look after him or herself, because the risk of the fall. I have already told you the sensory level. I will give you a little bit detail. Cerebellar, pure cerebellar can cause a feel like a weakness and ataxia, but cerebellar degeneration could be due to anything like an alcoholic, metabolic, a drug. Extrapyramidal is Parkinson's disease. The general weakness you couldn't find, I don't know, I couldn't find any foot drop. The patient is slow, patient is stiff. Think about Parkinson's disease. Okay, so because sometimes you don't think about Parkinson's disease, you are too focused, any foot drop, any proximal weakness. But when you look at the whole picture, that could be a Parkinson's disease. And autonomic function, is there any irregular RR interval in the ECG, or clinically patient has arrhythmias, or patient tell you the flushing, any evidence of the impotencies, urinary retention, lightheadedness, fainting attack, gustatory sweating, and hot and cold flushing, you name it. Okay, so next one, please. Now, after the examination, you can localize to some extent, like a brain. And if you have a brain, it's normally hemiplegic, isn't it? Unless you are bifrontal look, you probably look like a paraplegic. So the best example is a stroke. And sometimes it is just a cortex. So it's an apraxia. I will explain to you what is apraxia in the next slide. And the brainstem lesion normally associated with the cranial nerves, and spinal cord lesion normally have a sensory level. Spinal nerve roots lesion like alpine reticulopathy, the sensory disturbances are according to the dermatoma distribution. Motor weakness are according to myotoma distribution. There will be some pictures later on, so don't worry about it. Peripheral nerve, the best example is if you have an ulnar nerve damage, you have a little fingers and the half of the ring fingers. If you have a median nerve, you have a thumb and 2.5 fingers, for example. And muscle weakness and the pattern of the recognition, I'm not going to go into detail in this one, because that's overlapping with the previous explanation. Mononeuropathy is, for example, ulnar nerve palsy, or you have the fracture elbow, and you can have the ulnar neuropathy. So then after you examine the patient, you have to think about anatomic single lesion, where most likely mononeuropathy or reticulopathy or hemiplegia. Multiple lesion could be due to like a multiple system, like a rheumatoid arthritis, carpal tunnel syndrome, reticulopathy, and diffuse, symmetrical is most likely inflammatory metabolic. Or is that syndrome like a Parkinson's disease? Okay. Guillain-Barré syndrome. And then you have to think about it, genetic, like a Charcot-Marie-Tooth disease, infection, leprosy, for example, polio. I don't think you have seen polio. I don't know where the leprosy gone. When I was younger, I have seen many leprosy in Mandalay railway station. We have the over bridge. I was very young. I see so many lepers, and there's so many the people are begging for them. I don't know where they go now. And degenerative, like a neuropathy because of the diabetic. Inflammatory immunological, I have already explained you, vascular. Okay, now question. Charcot-Marie-Tooth disease, not Marie-Tooth disease. I will show you the picture later. Okay. Charcot-Marie-Tooth is a genetic neuropathy, hereditary peripheral neuropathy. Is called Charcot-Marie-Tooth disease. It was a French great neurologist, Charcot-Marie, and the English one is a tooth. They find out. Okay, so multiple and diffuse. Multiple is more or less patchy, if you like, and multiple is patchy. A diffuse is, how can I say? If you sprinkle your clothes with the spray, it is a multiple but patchy. A diffuse is if you steam the whole shirt, it is a diffuse with the steam. So I'm not quite sure I'm answering your question. So multiple is normally different multiple pathology, for example, but they can be sometimes difficult to, in the later stage, they can be overlap. But multiple is multiple site of lesion. For example, someone can have a carpal tunnel syndrome, and for example, multiple fracture. Multiple fracture is multiple because of the road traffic accidents. The fuse is an osteoporosis fracture. Am I answering your question? I will explain to you for the reticulopathy and reticulopathy later on. Okay, the next slide, please. Now, this is just a nice picture. Okay, so when you have a weakness, this is another way of you thinking. I'm sure you know that all you have to do is organize your thought, organize it. You already know what I have already told you. You might not know the detail, but you got the idea. All you have to do is organize your idea. All you need is a thinking process. So start with from the motor, brain, and then brainstem, then the spinal cord, and the nerve roots, peripheral nerve, and neuromuscular junction disorder, and methods. How would you know? Think about what I give you the talk in the previous slide. Symmetrical, asymmetrical, sensory involvement, not sensory involvement. For example, not sensory involvement, most likely muscle and neuromuscular junction disorder. Symmetrical, most likely a muscle disease, metabolic. Diffuse and symmetrical, like a collapse and stalking, is peripheral neuropathy. That's what I am saying. So this is your roadmap: brain, brainstem, spinal cord, nerve roots, peripheral nerves, neuromuscular junction, and muscles. And then look at the previous slide and apply it on that roadmap, okay, that framework. Next, please. Okay, so apraxia is normally you have a normal power, but you don't know how to use it. It is a computing problem. It's similar to dysphasia, motor dysphasia, sensory dysphasia, I'm sure you know. So apraxia is normally when you ask the patient to grip, they are all normally very okay. But if you ask the patient, can you show me how to comb your hair, how to do your bottom, how you to pull the zip, they don't know how to do it. So there are so many apraxia. And one of the apraxia is, for example, gait apraxia. One patient has a dementia, and they will tell you, oh, that is falling over, but he's not weak. Of course, when you look at the patient gait, patient is walking as if 2 years old, like a, how can I say, in Burmese, how can I say, လမ်းလျှောက်တင်တဲ့ကလေးလိုပဲလမ်းလျှောက်တင်တဲ့ကလေးလမ်းလျှောက်နေလို့ပဲတုံချီ it's a gait apraxia, right? So apraxia is normally cortical. So next slide, please. So this is a brainstem. So when you look at it, if there is a cranial nerves, most of the cranial nerves, not all, but most of the cranial nerves are located in the brainstem. So if you have a brainstem pathology, patient will have, you think about brainstem. Okay, of course, a 7th cranial nerve palsy, you have to do upper and lower. This is a peripheral nerve. Next slide, please. So I'm just giving you the picture and just to remember what I have said before. Upper and lower motor neuron lesion. Upper motor neuron started with the motor cortex and then and at the anterior horns. From anterior horns to up to the muscle is a lower motor neuron lesion. So that is an old chestnut. That is a pioneer part 2 level. So what is the upper and what is the lower motor neuron lesion? I'm not going to do detail. That is a self-explanatory. Okay. So because why it is important, of course, upper motor neuron lesion is normally central. You want to do MRI scan. If it is a lower motor neuron lesion, scan is not always essential. Some of the Burmese people are poor. Some of you are very practicing from the remote area. So you can't rely on investigation all the time. So it is important. And next slide, please. Now, myelopathy is look at the spinal cord. Reticulopathy is your spinal nerve roots, and of course, neuropathy. The best example, myelopathy is a spinal cord injury because you fall from the horse riding, and reticulopathy is you pull the heavy object and your disc prolapse. And neuropathy is, for example, you play the football and you fracture your tibia and fibula and you got a Brodian nerve palsy. So sometimes because the nerve roots are coming from the spinal cord, so it like a tree trunk and branches. So sometimes pathology, like say neurofibromatosis, it can be present on both areas, like a spinal cord as well as a root. So you can have a myeloreticulopathy. Okay, so I am answering one of the questions I was asked earlier. What that our answer, you both upper and lower motor neuron. Yes, if you have a myeloreticulopathy, you can have a both upper and lower. If you have a stroke as well as a neuropathy, you can have both. And if you have a motor neuron disease, you have a wrist reflexes, muscle wasting, you can have both. Okay. Now, look at it. So peripheral nerve and nerve relation reticulopathy. So that is, I'm answering one of the questions I was asked. Peripheral nerve lesion, if you have a weakness, you, in principle, okay, in medicine, there is no such a thing for always or never. But in principle, if you have a foot drop due to the peroneal nerve palsy, because of it, you have a fibular pressure or very tight plaster cast at your knee, it's normally used to be severe. And if you have the L5 lesion, it's not that severe. Muscle atrophy, I don't believe in it. I do not agree with this slide. I copy it from somewhere else. So in the muscle atrophy can be found in both conditions because reticulopathy is lower motor neuron lesion. From anterior horns is inside the spinal cord. Then you got the ventral horn. So if you have a reticulopathy, of course you can have a muscle atrophy, but not as bad as the distal peripheral nerve lesion. Okay. So these are the what are the autonomic symptoms? For example, lack of the sweating, dryness, and things like that. If you have a Horner syndrome, you're going to have an autonomic function. So that is also self-explanatory. Next one, please. So this is a brachial plexus. Okay, so if you have a medial cord lesion, you can see the yellow one in the lower. If you have a medial cord lesion or lower plexus lesion, you're probably going to involve both median and ulnar. If it is a more distal, you're probably going to have either median or ulnar. So by looking at what is the neurological deficit, you can work it out the location. It's not always easy, but it is quite interesting to work, to use your mind or your intelligence for the mental exercise. Next one, please. That is a sacral plexus, just for the reference value. Next one, please. Now, look at it, pattern of the weakness and clinical diagnosis. And unfortunately, it is too small for me. I can't see it. And so hopefully you can see it. I'm old man, my eyesight is failing. So if you have a myelopathy, yes, thank you. Peripheral mononeuropathy, you see the proneal nerve palsy is like L3 reticulopathy. So proneal mononeuropathy, L5, they are very similar. And then you have a myelopathy with the sensory level and herpes zoster with the dermatomal level. So they are all very self-explanatory. Okay, I don't think I need to go any further. And I'm just opening on my, I think probably I can see in my iPad, I can open it. So in the pattern of the weakness, look at it, hemiplegia, cross is a brainstem. Of course, you can have a cranial nerve, you will have a cranial nerves. Spinal cord lesion, paraplegia. But remember, this is important. Spinal cord lesion, sensory level involvement is always lower than actual level. Okay, if you have a cervical cord lesion, sensory level is not at the neck, it's normally at the chest level. So it is what happened was normally orthopedic surgeon, patient presented with the lower limb weakness, they do the lumbosacral spine and they say, oh, nothing wrong. No, I normally tell them, do the whole spine, please. Okay, so polyneuropathy like a diabetic, and myopathy normally proximal symmetrical. That's why that reference to my earlier talk. So brachial plexus lesion, commonest cause is trauma. Okay, another cause is like a Pancoast tumor. That's paraplegia, and paraplegia is more weakness. Paraplegia is a slight weakness. So they are basically the same. The difference is, it's probably the same. Paraplegia and paraplegia. Paraplegia I think they are the same. Paraplegia and paraplegia, like a Pani and Urake in Bali. I don't think there is any difference. Okay, now, so these are the picture. So you applied the previous, my slide. So next slide, please. Now, this is a pattern of the weakness, upper, lower, myopathic atrophy is normally disuse. Okay, fasciculation, lower motor neuron lesion, you can see the muscle twitching. And the tone is increased, myopathic, tone is not normally increased, but myopathic is because of the inflammation. So they are, some people do find a bit stiff. So they might interpret as a tone. In Parkinson's disease, we don't say tone, we call it in the Parkinson's disease, it's like a cleft-like rigidity, okay? And distribution, upper motor neuron is a regional, like a paraplegia. Lower motor neuron lesion is a segmented, again, refer to the previous slide, and myopathy proximal. Okay. Now, sensory involvement, both upper and lower, they have, because they are nerve, and myopathic is absent. Next one, please. So, pattern of the sensory distribution, these are the one of the slide in only the upper limb. When you look at it, there is a difference between the peripheral nerve and the myotome. So when you are examining the sensory examination, you just look at which one is more in keeping with my abnormal sensory findings. It's not easy. Sometimes it is misleading, but nevertheless, you got a rough idea. So next slide, please. I'm acutely aware that time, so I'm going to answer the question and answer if I have the time and the next. So I will ignore for the time being. So common peroneal palsy, again, if you have a pronoid nerve palsy and your problem is a dorsiflexion, but if you have a sciatic nerve palsy, because it's all down to anatomy, both plantar flexion and dorsiflexion. So it's all down to anatomy. So this is an example of the, by examination of the weakness, you can tell you whether it is a nerve or reticulopathy. Okay, next one, please. So this is an algorithm. And because this is again self-explanatory, and I'm not going to into it. So if you have a weakness, it's a unilateral, it's the hub of the body, and it is a lower motor neuron or upper motor neuron side. Contralateral, probably brain stroke. Cross paraparesis, just a brainstem. So these are the both. These are the like an algorithm. You can work it out where your weakness is, and then you can think about where the site of lesion. Okay, next one, please. Examination, blood, diabetes, B12, CK, because if it is a muscle disease, and poor blood count, patient has a leukemia, lymphoma, you name it. And also you can check the urine, and you also check like an autoimmune, like a vasculitis factors, ESR, and also genetic, like a Charcot-Marie-Tooth disease. I will show you some picture. And neurophysiological examination. And neurophysiology examination, it's a nerve conduction EMG study. Basically, I will show you the picture later on. And CSF, if it's an inflammatory, like a Guillain-Barré syndrome, and proteins are increased, and cells are not that increased. And of course, MRI, and also the nerve biopsy. I will tell you slightly more. Next one, please. So, you can have a magnetic stimulation and record that from your muscles, and that is looking at the integrity of the whole neural axis. That is one of the neurophysiology nerve conduction EMG machine. So you stimulate, this is a motor nerve conduction study. Stimulate in here, this is a median nerve, and this is a APB is median nerve. So you just got the nice normal muscle response. This is a normal result. And then you can calculate the velocities and everything. You don't need to know, but I just want to show you what is a neurophysiological test for someone who have not seen it. And then you put in the needles, and looking at the needles, and then ask the patient to move around and look at it, whether it is a normal, neuropathic, or myopathic. Okay, next one, please. And then look at the MRI scan, and look at that this is a disc protrusion. And if the disc is too protrusious too, but you can have a spinal cord lesion, and at the same time you can have a reticulopathy. You have a, back to the previous question, so you can have a both upper and lower, of course. And next one, please. Look at MRI scan. CIDP is a chronic inflammatory neuropathy. It's similar to Guillain-Barré syndrome, but the pathophysiology is totally different. Okay, and you can see very high signal changes in the nerve roots. So MRI is important. And another one, please. And look at it. And this is a muscle MRI scan. This, look at the distribution. Both are muscle disease. IBM, you don't need to remember, it's an inclusion polymyositis. This is a polymyositis. For example, the distribution is totally different. And when you look at the MRI scan, look at this is a distal rather than proximal. So you don't need to remember that's for that's someone who's practicing for the neurology. But when you look at the muscle MRI scan, look at the signal changes. Okay, look at these signal changes, the white one, heightened one. So you can see the MRI scan is not for the brain. So there is all sorts of things you can do. The next one, please. the biopsy, muscle biopsy, nerve biopsy. Okay, IBM is again, you can see this inclusion. That's why they call it inclusion polymyositis. Next one, please. This is a Charcot marine tooth disease. Someone is asking me, what is a Charcot marine tooth disease? You remember Charcot joint and like a table breezes and diabetes. It's one of the greatest neurologists called Charcot. And you know the high arch, embedded champagne border. And this is a champagne border. When you look at it, because they have a distal muscle atrophy, but they spare the proximal bulb, so embedded champagne. And you can see this is a contracture and the deformity. Okay, next one, please. So that genetic neuropathy. Now, management of the neurological disease. There are some neurological disease as a management of the for example, like a Guillain-Barré syndrome. That's emergency, especially if they develop neuromuscular failure, respiratory failure. Myasthenia gravis can present with the dysphagia, aspiration pneumonia, and of course, and Guillain-Barré syndrome can present with the autonomic dysfunction, arrhythmias, and so on. And spinal cord syndrome, if you have a cauda equina syndrome, paralysis, you need a neurosurgery. And so you have to think about putting on ventilator, and you have to think about respiration, cardiovascular system, autonomic dysfunction, and nutrition. And that's because they can't eat, they can't swallow, and secretion and posture, because a patient, some GBS were not better for 2 months. Now patient is better, but you got the knee and ankle contracture. So what is the use of the recovery? So make sure you have a back exercise, and the pain, patient may not be able to tell you because they are dysarthric. So make sure you observe the pain and rehabilitation, physio, and OT. So you need a supported treatment, avoidance of the complication, fall, burns, contracture, infection, UTI, deep brain thrombosis. They are also important. Palliative care, for example, someone motor neuron disease, terminal cases, you have to offer palliative care. And treatment should not be stopped because of the patient is going to die. The patient has right to die with comfortable and dignity. And hospice and genetic counseling. Next one, please. Approach is again, I know I'm talking about ideas, but hopefully in future, we will have this one. We will have this one. So we're going to have a team approach, neurologist, pediatrician, intensive care, cardiologist, even the short teams, speech and language therapists, physio, palliative care team, and even for the school, applies like a splint. Okay, next one, please. So look, this is a bantropic ulcer, and there's a risk, low blood pressure, falling over, falling and fracture. So these are the common symptoms of neuropathy. And for the joint, there is a, the bony mass. They normally have this sort of the ulcer, and here at the sole or ball of the feet. And next one, please. Now, the modern technology, that's for the future generation like you. And even this disabled patient trying to be independent, to promote a quality of life. And this is a very famous Stephen Hawkins. He got like a very computerized voice. We have a bounce bank. When the patients are okay, we normally put their patient in the computerized system and we can synthesize it. Okay. Technological advances, and also to prevent the contracture. This is a special boost you normally use in diabetes. And we can use a gene therapy, for example, for the kids, immune checkpoint inhibitor. These are the new medications. They all coming up now. So next one, please. Now, thank you.